All right, and residents are here. Residents, you're going to have to raise your hands because I would like to engage you in our surgery from last week. So can you guys raise your hands, and then Peter and Chris, can you promote them?
Yep.
All right, good. So I've got a few things to share this morning. People see my screen?
Yes, we can.
First thing I want to touch on was Title IX sexual harassment training. For the older ones of you, you may remember that Title IX is a law basically that was developed to deal with sexual harassment in sports, and mainly in college sports. Started in swimming and then extended all the way through all the sports, and now has become the mechanism for dealing with sexual harassment in the workplace in general. Mount Sinai has a fairly robust policy and a really good training module that is mandatory for everyone to take. It's another peak module. You know, we're all dealing with peak modules almost every week these days. This one is, it's really important. It's really good. It's incredibly well done. I did it a couple of days ago, and it does really take about 30 minutes. It's worth putting the time in, and you know, you'll learn a lot. Everyone needs to do it. Doesn't matter your gender, because anyone can be in a supervisory position, and anyone can be approached by a colleague who may have had problems. And there really is a better way to deal with it than what we might think is the normal way, or you know, the natural way to do it. I think one of the most important takeaways here is that it's not up to us as teachers, leaders, or supervisors, or colleagues to do the investigation or do an investigation. There are people who are designated to help with this if there is an accusation. And there is confidentiality that you can support if one of your colleagues comes to you with a problem. I did mine yesterday, so had not completed, but only 5 of us have completed it as of yesterday, and everyone in the department needs to do it. So I encourage you to go online to Peak and get this done. The deadline is not until the end of the year, but no reason not to do this as soon as possible. I'm sure most of you have heard by now that unfortunately Paul Singh is going to be moving on to greener pastures. Paul has been here for about 3 years. He's had quite a few accomplishments in addition to being just, you know, wonderful colleague and a great person to work with. I consider him a beginning of a friend. I'm sad to see him leave. He's really accomplished quite a bit, as you can see here. He really is appreciated by his peers, has been academically active, clinically active, and educationally active. He's going to be, his most notable accomplishment, and it's not his accomplishment, are his twins. And together, he and his wife are going to be moving closer to their parents. And he has also taken a position as associate professor in the departments of neurosurgery and neurology at Georgetown, where he'll be director of neuroendovascular surgery at MedStar. So Paul, it's been really nice having you. I hope that we stay very close. We're going to miss you, and wishing you the best. I'll briefly go over today's speakers. First, Danielle Wheelwright from Australia has been here for 5 years. Started out in research in neurocritical care when Stefan Mayer was here, and has now moved over for the past several years into the vascular program, where she is a vital and important member. I'm really glad that you are here today to talk to us. Divaldo, most of you know, is from Brazil, has done international fellowships and local fellowships, as well as our one of our fellowships here, and he is now ensconced at MSM, that's going to talk to us later today. Praveen will be introduced by Peter. I wanted to go through, we've kind of had a theme recently, surgically, of temporal floor Kawasi's triangle approaches, and so this was another example of that. By now, I know you guys are fully up to speed, and so I'd like to just show you a couple of pictures from this case. This is a woman who is an international patient traveling from Central America, kind of shopping around and settled with us here. One of the considerations whenever, in every case, is, what is their social support system? What are we discharging them to? And in a case like this, we want to make sure that since they're here in New York traveling, that whatever we do, if possible, will allow them to get back to their hotel and travel back home as soon as possible after treatment of the case. One of the features is that she's blind from a traumatic car accident many years ago, blind in the right eye. And the tumor, as you can see on the right, is right image here, starting to encroach on the optic chiasm. It's invaded into the sella, and actually through the sella into the sphenoid, and there is some threat to the opposite side. It has encased the internal carotid artery, as you can see here. So that manipulation is why she went. And also goes down pretty far into the posterior fossa. We discussed preoperatively that this represents the tentorium here. So there's extensive involvement, but we're at an advantage in a case like this because her eye is not functional. She has a prosthesis here, and that gives us all kinds of leeway as to what can be done. To me, the key parts of the surgery are to decompress this posterior fossa part of the brainstem, to allow for postoperative radiation if it grows back, to remove the temporal lobe and frontal lobe compression, and to avoid damage to the carotid artery and the anterior carotid artery. Her main symptoms are progressive headaches that have become disabling. So here's some of the analysis we like to do preoperatively. Our vascular structures here are very important, and you can see that Dennis from Surgical Theater has nicely outlined the basilar arteries, superior cerebellars, right PCA, left P1 in blue, the PCOM, and the P2 over here. The other really important part, since we plan to be looking past the tumor and into the posterior fossa, is where is the Petrous portion of the internal carotid artery? Because this is at risk as we go through the tumor. Remember that our lateral border of Kawasi's triangle was the horizontal portion of the Petrous carotid. Remember that from one of our recent discussions. And so now this is distorted by tumor. As we go through the tumor from front to back and top to bottom, we're going to be coming over the top of the carotid. We want to know where that carotid is inside the tumor. And that becomes a key part of this surgery. Here's the fly-through showing the previous reconstruction. So as we spin it, we're looking for, here now it's transparent, so we want to look for the internal carotid artery that's coming down over here. And we also want to look for the PCOM and anterior choroidal. We may not see anterior choroidal, but we'll see the PCOM. And you can see it right here. Boom. Sorry, the boom didn't work. All right, the pause isn't working. I don't want to get too into this. So the first part is a bicoronal opening, which you had before, and there's Alyssa and Ernest reflecting the scalp and getting the exposure are set up in the operating room. The heads-up display that you're so used to seeing now. And then the initial approach, and this is often where you spend a little time sort of getting yourselves oriented. So I see Matt Carr, you just happen to be in an unlucky spot on the Zoom participants there. So Matt, this is a right frontal approach. This is the right orbit. And just to get oriented here, remember that our heads-up display shows us on, do you see this dotted line? That would be where the machine thinks the border of the tumor is. This is where the optic nerve should be. And then you see the, can you see the where the carotid should be there? Matt, do you see the dots?
Yes, yes. So you cut off there. Yes, I see the dots.
Okay. So now, first is the overlay. Now let's look at, this is our very, very first exposure after putting the retractor on the frontal lobe. So this is the retractor. What is this over here, Matt?
It looks like a nervous structure.
It's part of the temporal lobe.
Could that
So that's
be
the superior part
temporal
of the temporal lobe. We've got our retractor on the frontal lobe, and there's arachnoid of the Sylvian fissure. There's the tumor below it. And Jacques, you see this? So as we look to the left, we know there's the orbit. We see that the dura ends right here. You see my mouse?
Yeah, I see it, Dr. Petrous.
Okay. And then coming out, you see something white. So this is dura white. What would this be?
That would be part of the frontal lobe.
Alex?
Is it the interclinoid?
Abi?
Part of the orbital muscles.
Ray?
The optic nerve.
Yep. Bingo. Okay, so orbit, falciform ligament, and optic creeping out here. So remember Cal's famous 3 words: believe your eyes. Believe your eyes. We don't want to always be relying on our heads-up display and our navigation because it can be off. And here it's off because the optic nerve in yellow here is about 1 centimeter off to the right, and it's twisted. So part of our, if we're going to use heads-up display, part of our protocol is that we're going to go into re-registration mode. It's called navigation update mode. And you're going to drag and twist the image until it overlays. And now we have a very good landmark here because we see the optic nerve. Okay, so there's the tumor, temporal lobe, arachnoid. Next here is we zoom in to confirm what Ray told us, and that confirms that this is the optic nerve. Okay, so Halima, where would the carotid be in relation to this?
It would be lateral to the optic nerve.
Okay, and which direction in this film is lateral?
So it will be towards the right side of the screen.
Good.
So
Okay.
on like where the tumor is marked in purple should be sort of under,
Okay.
beneath.
Well, actually, you can see a little red right here. And what you can see on the heads-up display is that this is the lateral border of the optic, and the carotid, which is this red, I don't know if you can see it so well, it's only less than 1 millimeter away. So we go back to the optical image and we see the lateral border of the optic and we see the medial border of the carotid. And so now we have readjusted the heads-up display and we see the carotid overlaid on the actual carotid. And the other thing you see is then you see the tumor where my mouse is, but between the tumor and the carotid, you see something white. All right, Halima, you're on a roll. What would that white structure be potentially? Travis?
Not sure.
The third nerve.
That's third nerve. Bingo. Okay, so now we're starting to get the lay of the land here. And this is really important, this part where you're kind of poking around or looking around and just orienting yourself, getting yourself set to start. You can confirm the carotid artery with the Doppler. We can look over the top of the carotid and under the optic. And we can start removing tumor lateral to the carotid. Remember, one of the biggest causes of a deficit in this patient is going to be the anterior carotid artery. And here you see the PCOM, and then this is, we hypothesize, might be the anterior carotid, this little nubbin right here. And we blow that up and confirm later that that is the anterior carotid, which is confirmed. You can Doppler the anterior carotid. Look how much smaller the carotid is than the Doppler. Doppler is about 1 millimeter or 2. The anterior carotid is a very small and unforgiving artery, but it has its own voice, and you can hear it with the Doppler. So once we've done that, we'll then protect that with a cottonoid, because we know that's going to sort of provide a medial border to our resection of the tumor. So then we turn laterally, and we go all the way as far laterally as we can go. We cut the tentorium, and we get into the posterior fossa towards the lateral aspect of the tumor. This nubbin here is the part that's going into the sphenoid. Here we're lateral to the tumor. And we need to now connect these dots from lateral to the tumor on the temporal floor to medial. We need to come across this base of the tumor, but remember that our carotid artery is inside, deep. And here you see using the handheld navigation device. And does anyone know why, if I have heads-up display, that I want to use the handheld navigation device? Alejandro? George?
At this point, there may have been shift of structures and
Okay. Well, you know, normally the two will correlate. Here we're using the Sonopet, getting actually into the posterior fossa here. But why would I use, George? Why would I want to? What is the point of using the handheld?
if I can add to that, you know, also the zoom of your scope may not be exactly
don't guess.
where you.
Alejandro, don't guess. Alex?
It can also serve as a dissection tool while you're looking up at the screen navigating.
Okay, good thought. George, I didn't hear from you.
Yeah, we want to confirm where we are with the navigation to combine it with a heads-up display.
Okay, this is kind of a detailed technological question, and I don't expect anyone to know the real reason. The real reason is that heads-up display requires a projection of data from BrainLab into the microscope. But remember that the only way that I was able to see where the Petrous portion of the internal carotid artery was on surgical theater. And right now, due to I want to say a financial issue, or it may be corporate, BrainLab has not permitted data to flow from the curve into surgical theater. So we cannot use heads-up display in surgical theater. The only way that I can navigate in surgical theater to link our anatomy to the 3D scenario is by using the handheld probe. And so that's what you see here, using the handheld probe. And then we go back to this, and remember that the Petrous portion is inferiorly displaced. And this is kind of our view now. We're looking down pterionally we've identified the PCOM, we've identified the supraclinoid ICA, and we know that deep inside where my mouse is this ICA, which we've got to remove all this tumor, then go over the top of the ICA. And here you can finally see our probe coming in. So I know I'm very close to it. You don't see the Z-axis here. I would have to rotate this for you. But this shows now that I'm pretty well aware of where I am relative to the carotid artery. And I know I'm gonna have to radiate, so I'm gonna leave a good amount here. And I'll leave the entire Meckel's cave component. I'll leave everything that's compressing this carotid. Here you see what it looks like during the surgery. This is my sucker. This is the probe that then relates to this. As you can see, I've had Dennis rotate the head. You see the head on the bottom? So in surgery, we're looking from a terional view. And in navigation, we're looking from behind just so I can see the overlay. I hope this makes some sense to you. So now I know I'm home free. I can slip over the top of the carotid and get into the posterior fossa. Finally remove that component, and we're looking way down in the posterior fossa and see this structure here. So who is next? Kurt?
Sixth nerve.
Sixth nerve, exactly. And we know that as we get down on the clivus, that we'll start to see the sixth nerve. We know she's got a fixed eye, so I'm okay with that. And then this would be the final view. We see Ike here over the surface of the brainstem. We saw that preoperatively. I didn't show it to you. We then have to clear the supraclinoid components, so we're looking back up here to the lateral aspect of the carotid, PCOM, choroidal. This is third nerve that we've taken. And then once we take that, we can retract the carotid laterally, reach across to the opposite optic, take this tumor out. And this is the pituitary stalk here going from inferior to superior, which is why she developed a little bit of DI due to this manipulation. So there's the final view showing the tumor that's in the posterior, in the cell of the sphenoid, the Petrous component, but that we've done what we came to do in getting rid of that compression of the brainstem there. Okay, sorry that was a little bit long, but I'll turn it back to you. Thank you, Chris.
Okay, great stuff. So we're ready for Danielle. Danielle, are you here?
I am.
All right.
Hi. Let me share my screen. You see that?
Yes, we can.
Yep. Okay. Okay, so my name is Danielle Wheelwright. I oversee stroke quality for the health system, and I'm going to spend about 10 minutes or so going over some stroke volumes, some process metrics, and just give a few recent updates. First of all, I think a lot of you already got this memo, but we did, Mount Sinai Hospital received they give out an annual stroke award, and we just received this about a month or two ago. We got a Gold Plus Target Stroke Honor Roll Elite Award, Achievement Award. It's based on, how we meet our target metrics and a bunch of other things. Believe it or not, there's still one more level that we can go higher, which has to do with our TPA times. But congratulations to everybody, because it is a huge achievement. Not everybody gets this level of award. So just looking at our system volumes and IV TPA data for 2020. So we know that during the peak of COVID, most of our sites throughout the health system saw a drop in stroke volume. So we're just interested to see how that's affecting, or how that will affect our overall volumes for the year. So I'm comparing throughout these next few slides to 2019 and 2018. And usually from year to year, we see an increase in volume. And you can see so far through January to July, we've had about a 150, 160 drop in volume. And to be clear, this is ischemic stroke, TIA, subarachnoid, and ICH. And then breaking that down by diagnosis, along the x-axis here, we have diagnosis, and z-axis here, we have the year, just to see exactly where those falls in volume are. You know, 2019 and 18, we had volumes of about 850, 860 for ischemic stroke, and we can see that drop here down to 771 for 2020. SAH seems to be fairly stable. We can see a drop here between 2019 and 2020 of ICH of about 40. We see this jump up here of ICH between 2018 and 19, and I think that reflects the growth of Dr. Kellner's SCUBA program. And we've definitely seen throughout the system a big drop in our TIA volumes. And that's because people aren't coming to hospital with those milder symptoms. And then finally, just looking at that data site by site. So along the bottom here, we have each site throughout the system, including Elmhurst, and again, the years here. Everyone's fairly stable, but we're noticing that reduction in volume mostly at Mount Sinai Hospital, Mount Sinai Queens, we're seeing that drop, and Mount Sinai Morningside and Elmhurst. Fairly colorful slide here, but this is looking at our TPA volumes for the last 12 months broken down by quarter. I won't go into it too much, but you know, unsurprisingly, Mount Sinai Hospital has the highest TPA volumes. This does include mimics as well, given in the last 12 months at around 55, followed by Queens, and then Elmhurst, and then the others are sitting just over 20-ish. Interestingly, though, we're seeing this drop in TPA volume at Mount Sinai West, Morningside, and BI. So we'll see if that picks up as we progress through the year. You know, we're always trying to move really fast in stroke, and there's a lot of time targets that we have. And for our IV TPA, our time target across the health system is 45 minutes. Obviously, we track and present this at all of our quality meetings. So just to give you an idea of how we're all doing, at the front here, we have 2020 times compared to 2019 times at the back. And most of the sites are hovering around the 45-50 minute mark. You can see a big improvement between 2019 and 2020 of West. And that's because the residents moved over there. So we're seeing improved process with those cases. And Mount Sinai Queens have been doing a lot of work with their door to needle time, because that was actually one of their citations when the Joint Commission came for their stroke survey last year. So they've been working really hard and have seen a good reduction in those median times. And FYI, the DOH is now pushing that target to 30 minutes. So we sort of, it used to be 60, they push it to 45, and now they're moving it down to 30. So still more work to be done there. And then moving on to some endovascular intervention metrics. And I'm presenting here a 12-month period looking at October 2019 to September 2020. So the black line here represents the entire health system volume. Any 12-month period, it really sits between that 200 and 225 mark. I think off the top of my head, this was 216 or 217 for the last 12 months. And you can see there the different sites represented there. Sinai was around 80, Mount Sinai Queens, whose stroke center opened, I think about a year ago, maybe a year and a half ago. Their volumes are really jumping up. They have had about 50 cases there in the last 12 months, followed by West and then BI. And then we break that down by month. Again, the black representing the health system intervention cases. Usually we see about 15 to 20-ish cases per month. January, we had this, outlier month of over 25 cases, which we really can't explain. We did see this peak in April during COVID, and then the last few months, or the next months after that, really dipped off, and then we've had this increase here in September, around 22, 23 cases. Just like our IVTPA, we are really trying to get our patients to the IR suite as quickly as possible. We have time targets for this as well, of course. Our time targets for this across the system for patients who arrive fresh off the ambulance or who are direct walk-ins, we have a daughter groin puncture target time of 90 minutes, and that's represented here by the blue bar at each of the sites. And then we have a target for 60 minutes of door to groin puncture for those transfer patients. Obviously, those patients have already been worked up at the sending site, so it's going to be a lot quicker when they arrive to wherever they're going. So, you know, for 2020, we have seen definitely in the last quarter or two, an increase in our EMS cohort, and that's because all of our patients are PUIs, COVID PUIs, and there are more room prep and PPE prep that has to be done. And so we're seeing about a 10 or 20 minute delay in some of these cases now. So hopefully, I think some of the ED sites are getting point of care rapid COVID testing where results can come back in, you know, 15 or 20 minutes. So hopefully we'll see a reduction in those groin puncture times. And, you know, shout out to Queens here with this 33-minute daughter groin puncture time, because they have this stroke center where they literally can wheel patients straight in to the suite from the ambulance. So, you know, those times are really amazing. And then moving on, so, you know, the Joint Commission sets out all of these stroke core measures and comprehensive core measures. A lot of them have to do with documentation of various severity scores and things like that. We track these. It's pretty boring to track and it's pretty boring to follow up on, but it's still important because the Joint Commission does, you know, check this, and we have to report back to them monthly on what our compliance is to all of these. I'm only going to spend my time talking about the ones that are relevant to this group and where we're sort of falling out on a little. The first one is a comprehensive stroke measure. We are required to document NIHSS for all ischemic stroke patients within 12 hours of admission. So we're actually doing pretty well here. I just wanted to mention it as an FYI. We sit around the 90-ish percent mark here. And just to be aware that we do need it within 12 hours or prior, I say thrombectomy here, but any procedure that happens. And that's the same for all of our severity score documentation. So they have, if they have an EVD placed, or, you know, if they go to OR or anything like that, the documentation of this has to be before that.
Yeah, we have about 2 minutes left.
Oh, okay. And then the next two, I'll combine them, are Hunt and Hess documented for SAH and ICH score documented for ICH. So the only difference here for then compared to the NIHSS is that it has to be documented within 6 hours. So really, this is my sort of biggest message to this group today, you neurosurgery residents that often see these patients before they move to OR or IR, is we've included, I don't know where it sits in your H&P template, but you can, it's there somewhere. So just make sure you document the ICH score or the Hunt and Hess. And Connor, my colleague, he's a stroke coordinator for Mount Sinai Hospital, sends out a daily email to follow up on any outliers. So if you receive this email, please, please, please go back and just add that severity score, if you can. And nimodipine, we want that administered for all SAH within 24 hours.
Danielle, let me just jump in real quick. Guys,
Yeah.
that's the crucial part of all of this
Yeah.
It's absolutely critical that when you do your H&P that you put in an NIH stroke scale or a Hutton-Hess score. It's very big. You just got to write a Hutton-Hess score. Hutton-Hess grade 1, Hutton-Hess grade 2. You guys always say it on rounds every morning. All we got to do is make sure you put it in the H&P, please. That's the critical component.
Thank you. And then very quickly, other updates. We have been working on our ICH policy. We're creating an ED ICH order set that will be finished hopefully within the next week or so. We talked amongst ourselves with neurosurgery, neurocritical care and stroke, and we have all agreed upon a blood pressure target range for ICH of 130 to 150 systolic. So I'll be updating the policies and order sets and everything to reflect that. And just a reminder, our bedside NDT huddle is required for our post-thrombectomy patients, also our LVO chance patients. This is sort of a new thing. Really, really important that this happens with the bedside RN. Get him or her to stop and be involved in that huddle for both of these situations, just so that they're on the same page and know what the exam is, blood pressure targets, etc. Yeah, and finally, if you get that QA email, it's blue and it's green and red and orange and very colorful. You only get it if there's something that we need you to follow up on. So please read it and please follow up if there's something that you've missed. Thank you. That's it.
One quick data clarification, Danielle.
Yep.
All that you were showing comparing the years,
Yeah.
are you annualizing 2020?
No. That is just January to July.
So you were comparing 3 quarters of January of
The same
2020
period.
to a full year of the other years.
No. It's the same period.
So you were only doing the first 3 quarters for the other years.
Correct.
Okay, great. Thank you.
Yeah.
What's the data source for the numbers?
Get with the guidelines. Get with the guidelines for these volumes for this first half, and then the endovascular volumes is the red cap, endovascular red cap.
About the ICHs.
Get with the guidelines.
All right.
Okay.
Great, thank you.
Thanks. Let me just unshare.
Okay, next up, we're going to move to Divaldo. Divaldo, are you available? And we're going to try, Divaldo's going to try polling. So we're going to activate polls when just let me know, Divaldo, when you're ready for that, and then I'll activate the poll.
Yep. Okay. Can you guys hear me okay?
Yes, we can.
All right, cool. I'm going to share my screen. Hi, good morning, everyone. I'm Divaldo Camara, neurosurgeon attending at Mount Sinai Morningside. And I would like to review today some interesting cases that we have here, and they are interesting for educational purposes. No disclosures for this talk. As maybe some of you know, Mount Sinai Morningside is a very old hospital. One of the oldest in your city, was built in 1946, was formerly known as St. Luke's Hospital, then Mount Sinai St. Luke's, and since last year, Mount Sinai Morningside. It's 114th Street and Amsterdam Avenue. It's a pretty beautiful neighborhood, just a few steps from Columbia campus and Riverside Park, Morningside Park, and Central Park. It's primarily a trauma center. We are a level 2 trauma center. So as you can imagine, emergencies are a significant volume of our cases. However, more recently, with the great support of our hospital, especially Dr. Bettis and Dr. Gatan, we have established our neurosurgical service with the goal of not only having a trauma center for our Mount Sinai Health System, but also to expand for elective cases for spine and cranial cases. And I think we have advanced pretty good in the last few years. Just a fun fact. St. Luke's Hospital dedicated some floors to Titanic survivors. This is a New York Times cover from that year. And many of the survivors came here, but unfortunately we did not save Jack. We are blessed to work with an amazing team. We have an amazing PA team. This is a interesting hospital because we don't have residents rotating, so it's attending and PA running only. And we have had great results. This is our team during COVID time, during also COVID when we were receiving many donations. And briefly, I would just like to show this. This is ACS, American College of Surgeons report for this year, where we were compared to other hospitals with other trauma centers in the country. And as you can see here, for severe TBI, we have 2 times patients coming here have 2 times chances of a better outcome than average in the US. So that was a really, really great result for us. Before I dig into cases, I would just like to bring awareness about Revel. Maybe probably you have seen around the city and even other cities in the US, not only New York, Revels. These are electric mopeds you can very cheaply rent. As these are photos taken from their website, seems joyful. It's, have a good time riding the electric scooter. But that's how it's supposed to be. This is the reality. These are some pictures that I took around the city. Here you can see there's a guy unhelmeted crossing the red line just in front of our hospital. As you can imagine, this will not end good. This is also Revel patients that we have received, all with severe TBIs and with significant neurological problems. This is all over the news. Many deaths and severe injuries have been reported. It was actually suspended for a few months, and then more recently it was reinstated. So right now you can already rent Revels and walk around. Just last week we operated this lady that you can see here, this 82. She was hit by she was struck by a Revel, and that's sorry for the graphic images, are her brain, and that's brain coming out from her ear. That is how severe Revels can be. And we are getting together the database, and we are studying in detail all those patients, and we plan to publish that to bring awareness of this this moped. So back to our subject here, neuroemergencies. It's it's a significant number of cases we do here. I would like to present some category 1 cases that I had. It's mostly about the thought process and what went into the thinking of taking the patient to the OR or not taking the patient to the OR. And that's, I think for emergencies, that's something very critical. It may not be the surgical technique itself. The surgical technique may be straightforward, but to me, what makes it special for emergencies is your decision-making process. Of course, you don't have the luxury to select the patient. You don't have any time for medical clearance. So you may have old patients with a lot of comorbidities on Coumadin, which of course will impact your outcome. So my first case, this was a patient 2 years ago. She was admitted as unknown, 19-year-old female pedestrian struck by a bicycle. Trauma call was called. She was seen in the trauma bay. She was stable with the GCS 14, so just a little bit disoriented. Primary survey didn't see anything more concerning. Secondary survey, also she was stable, no other injuries noted. Her neuro exam was GCS 14. She was confused, but otherwise she was intact, non-focal, pupils were equal. However, a few minutes while still in the trauma bay, she became much more agitated and lethargic and required intubation. And for that, I would like to pause and just bring attention for agitation. It's very common to see ED patients being agitated. And as you can imagine, of course, many of the causes of the agitation can be intoxication, alcohol, drugs, which I think may be the majority of those cases. However, it's not unheard of, and I've had cases where patients were just deemed intoxicated, and that was the reason for their agitation, and later on were found to have a significant intracranial bleeding. So agitation can be a sign of intracranial pressure, increased intracranial pressure for any source. So don't take for granted those patients. So you may lose time to diagnose a reversible neurological condition. So this patient went for a CAT scan, and can you guys see the video? Okay.
Yes, we can.
Good. So this is her CAT scan. So she has some interesting findings. So left temporal epidural hematoma and a right subdural hematoma, some interhemispheric subdural, and some traumatic subarachnoid hemorrhage. At that time, she was sedated because she has just been intubated. So, I would say her neuro exam was probably around, her GCS was probably around 10. Her pupils were equal, and that was the bone window showing this temporal fracture. So that's her diagnosis. So she had a left temporal epidural, right subdural. And I would like to launch this poll. Chris, do you launch
Okay.
on, do you?
Yep.
Yeah.
Yep. I'll launch it. Okay, everybody, launching a poll.
So for this case, what treatment is indicated? Non-surgical, ICP both, also non-surgical, right hemicrania and left craniotomy plus ICP both or EVD, or right hemicraniotomy, hemicraniectomy for subdural and ICP. Basically, you don't do any surgical treatment. You treat the subdural, you treat the epidural, you treat both, or don't do anything. I think you have to click submit, Chris.
You know, I can just see the poll in progress.
Do they have a launch button?
So far, we have 21% of people.
Oh, okay, good.
Yep. Are you able to see the results, Divaldo?
No.
Okay. I'll give it up to a minute. It's at 50 seconds now. So go ahead and put your answer in. You've got 10 seconds to answer. Okay. There you go. Can you see that, Divaldo?
No, if you can just tell me which.
Okay. The result is 67% said left craniotomy for epidural. Oh, here we go. Sharing results.
Oh,
there, can you see
great.
that?
Yes, yes, I can.
Great.
Great. So this actually was what interesting result. Yes, that's actually what I also thought doing. But I think it's like would be. I understand this case if you would treat the subdural hematoma and also the left epidural hematoma. I know this is. I think both alternatives would be really acceptable. My thought process was to treat quickly what I thought was causing her decompensation, which typically is the epidural hematoma. So she literally had that lucid interval that we all talk about, epidural hematoma. So she was taken to the OR for a small crani for left epidural hematoma evacuation, and of course I placed the bolt. So she was taken to the ICU. She initially had, in the first few hours, the ICPs were under control. However, shortly she required mannitol, hypertonic saline, and we repeat the scan that showed more pronounced edema on the left side, and the subdural was not really much increased. She had more contusions on the right side. I'm sorry, but her ICPs really became refractory. From that time on, we decided to do hemicraniectomy. That was just a few hours after the first procedure, and that's the hemicraniectomy. So she did, initially she was intubated for a few days in the ICU with some ICP issues. We were managing with, mannitol, hypertonic saline, all the conservative treatment at that time. And she was finally extubated. She went to rehab, had a, pretty good outcome. This is her cranioplasty, and that's her recovering from cranioplasty. She's a Columbus student doing very well right now. So just a quick review. Epidural hematoma, you want to treat with surgery any epidural hematoma greater than 30 cc's, regardless of the GCS score. You may treat conservatively if there's less than 30 cc's or less than 50 millimeters of thickness or 5 millimeters of midline shift. If the patient has a good neuro exam, meaning GCS score greater than 8, without any focal deficit, without any pupillary changes. Those cases you may not treat surgical, however, you have to really closely monitor in the ICU. And for subdural hematomas, you want to treat surgically any subdural hematoma greater than 10 millimeters of thickness or midline shift more than 5 millimeters, regardless of the GCS score. You may also treat surgically if the patient has subdural hematomas less than 10 millimeters or midline shift less than 5, if the neuro exam is deteriorating, which I think was in this case. So if the admission GCS is deteriorating, if it's decreasing more than 2 points, or you have an ICP bolt and you see the ICP spiking, you may also want to treat that subdural. Cool. So that was the first case. Second case, it's a very sad case. She's a 35-year-old female, history of depression, anxiety. She was pregnant and she attempted suicide by jumping through the window, and she fell from 3 stories. She was found on the sidewalk, on cardiac arrest, CPR was done, ROSC achieved, brought into the emergency room. She was known to be hypotensive, FAST was positive, massive transfuse protocol was initiated, right pneumothorax was found. And I saw this patient myself, this was during COVID time on a Monday. She was GCS4, left side anisocoria, raccoon eyes, and she had extensor posturing. So very concerning neurological findings. So for this patient with severe TBI and and seems like very severe trauma, what would you do?
This one,
So
just give me 30 seconds.
yeah, take this patient for a CAT scan and plan surgery according to the results, straight to the OR for exploratory laparotomy, straight to the OR, and doing an exploratory left craniotomy because she has a left-sided isochoria. EVD ICP both placement in the OR, in the AD, or ICU admission and goes off care.
Give 5 seconds.
Yeah, I would love to get a CAT scan in this case, and I think that would have helped a lot. However, she wasn't stable. She was requiring massive transfusion protocol, and she was hypotensive and fast positive. So this was not a stable patient to be taken to the CAT scan. No time, we could not lose time to get. How can I get this? Can you close in your end, Chris? Yes, thank you. I'm not. Okay, so this patient needed to go to the OR without any intracranial, neuro image. Otherwise, she would have pretty much died from her hemodynamic instability. So she was taken to the OR for exploratory laparotomy, and then later on, right after, she was brought to the CAT scan, which showed some diffuse edema, maybe from the time related to anoxic encephalopathy, and a small right epidural hematoma, some small contusions, but really no significant intracranial mass. And I was concerned about her left endochoria, meaning did she have epidural hematoma that we were delaying that treatment? And briefly I thought about an exploratory craniotomy while she was in ED in OR for her abdominal surgery. I'm glad I didn't proceed with that, but maybe that will also be acceptable. This is just a CAT scan showing she had many skull-based fractures, and then the reason for her left endochoria was actually orbital fracture injuring the optic nerve. Okay, so she went to the OR, to the ICU. ICP bolt was placed. Initial ICPs were, just a little bit increased. That time, I would like to know what treatment people would do. So patient with severe TBI in CQ, she was now stable hemodynamically. ICP bolt was in place, ranging from 22 to 29. So what would you do right now? Right hemicranie, left hemicranie, orbital decompression, skull fracture elevation, medical management of increased ICP. Okay. Yes, correct. So she didn't have any significant localizatory finding on her CAT scan that would prompt a decompression at that moment. Chris, can you close? Okay, good. So that's exactly what we did. We followed the ACS guidelines, and this is a very interesting paper on the right side of the screen. This is an expert panel that tried to stratify an algorithm for severe TBI treatment, and we follow that. We have reviewed with our team. It's stratified in tiers from tier 0, tier 1, tier 2, and tier 3. These are for severe TBIs, patients with ICP monitoring, either EVD or ICP both in the ICU. So basically how to manage those patients. And tier 0, we basically, you're not actively treating any intracranial, any raising ICP. And then from tier 1, tier 2, tier 3, these are ranging, increasing treatment of ICPs, medical management of ICPs, and one of them being decompressive craniectomy. So this patient did initially okay, given her, already very concerning prognosis, but ICPs was pretty much controlled. She did receive some receiving mannitol, hypertonic saline, but she held throughout the next days. We did need to place an EVD for ICP control, which is one of the things you can do other than surgery to control her ICP. She did respond well with the EVD. She was bradycardic that day. She improved from that. So EVD was effective to provide some relief for ICP. However, she was decompensating much more. We was rounding with the NEMAT team. This is John Leung and I. John Leung is with the robot rounding remotely from Mount Sinai West. That day, that was day 6 since her admission. We were maxed out in mannitol, hypertonic saline. You were already doing hypothermia, and we were not being able to control her intracranial pressure. This is her CAT scan that showed already some much more effacement of the sulci and the right posterior temporal ischemic area, and a new right to left midline shift. She also has, you can see, a left frontal contusion and a small epidural hematoma. So we discussed the case with the family, and the family was adamant about all treatment to be done. And with that CAT scan, what side would you decompress? She has a right ischemic area and a left frontal epidural hematoma and a contusion.
Can you play the scan again?
Sure.
Five seconds left.
Yeah. Yes, so that's what we did actually. So, she did have left-sided concerning findings as well, but the midline shift was right to left, and that right ischemic area was much more posterior. Should we have done a bifrontal craniotomy, which could be an alternative for this case, we wouldn't have decompressed this area here. That's where I was concerned. So we did a right-sided decompressive hemicraniectomy. You can see here her intraop findings and the proper temporal decompression. That is her post-CAT scan after decompression. Her bradycardia really resolved, as you can see there on the 23rd, that was the day when she had the hemicraniectomy. From that day on, she was not requiring any mannitol bradycardia resolve, so that was really effective. Unfortunately, she did not have any meaningful recovery. That's her MRI showing extensive, injuries to both sides of the brain, also brainstem. But we honored the family wishes. Okay, my third case. This was an interesting case. 96-year-old female DNR/DNI. When you hear that call, when you are called for a 96 DNR/DNI, you don't think that's a surgical candidate, right? However, this was a very healthy 96-year-old. She just had hypothyroidism. And she went to MSM ED, complained of headaches and visual changes. And upon exam, she was, N times 3 full strength with bitemporal hemianopsia. Her labs were drawn, and later on came panhypopituitarism. And she was placed on steroids because of this finding. So this is her CAT scan that showed a large cellular mass with some right-sided hemorrhagic component. And that's her MRI, which showed large macroadenoma. The MRI had terrible quality. She was moving, at that time she was more agitated. And a few hours after admission, she started to have new findings. She was having a third nerve palsy and sixth nerve, and a few hours after, left side blindness. She was amaurotic on the left side. So she was progressing for her pituitary apoplexy. So with that clinical finding, 96-year-old, what would you offer for this patient? She's a 96 DNR/DNI, but healthy, fully functional, with ongoing pituitary apoplexy. Endoscopic.
We're gonna have you go to 8:05. Okay, so that's 6 minutes left.
Okay. So did you offer endoscopic transfemoral surgery, goals of care, palliation comfort, no role for surgery, medical management of the pituitary apoplexy, or goals of care? You discuss and offer goals of care, comfort, medical management, and eventually endoscopic TSS. Yeah, that's what we ended up doing. However, in this case, and I remember calling Dr. Gatan for to see, am I crazy to consider surgery for this? And then he said, well, you are not, but discuss with the family and the patient all choices they have. And the patient was very, very reasonable, and so her family. The patient said, doctor, I don't want to be blind. If I die during the surgery or after surgery, I'm fine, but I don't want to lose my independency. So I'd like to do everything I can to preserve my vision. So she was emergently transferred to Mount Sinai West the same day. And then I took her to the OR overnight, right after she arrived. By the time she got to Mount Sinai West, she was already blind in the right eye as well. She went to the war with, she was fully blind, which was very scary. I never thought I would see that progression in such short time. We did have, we just had navigation of from the CAT scan because her MRI didn't have good study. The volumetric was non-existent. But, you know, given her very concerning findings of blindness, I didn't want to lose time to get a new MRI. I decided to just proceed with the CAT scan. And during the case, actually, the navigation was totally off. We had no navigation, which also points how important it is for you to be prepared to, complete the case without the aid of navigation. If, for some reason it fails, you got to know the anatomy. In endoscopic cases for pituitary, you have to know all the, important landmarks to be able to complete the case if you don't have the luxury of a navigation. That's her post-op MRI. There's tumor left, but it was not my intention to provide a full total resection. I just wanted to decompress and improve her vision and cranial nerve deficits. That's her post-op images. She regained beautifully her vision. The left side third nerve is now fully resolved. Some a little bit of residual sixth nerve. How much time do I have, Chris?
I think this should probably be the last case. We have just a few minutes left.
Okay, cool. So yeah, so maybe another opportunity I can review the other cases. So just a review of pituitary apoplexy. She really had the classic presentation of pituitary apoplexy. She was a microadenoma. She had headaches, vision loss, fatigue, and pan-hypopituitarism. And then she improved as expected from the vision loss and the headaches, and her endocrine status also got better. Okay, so for the interest of time, I'm not able to review the other cases, but I guess those three cases are, example how we can the thought process that goes into dealing with category 1 cases and what you have to put in consideration when you're planning the treatment of those cases. Thank you.
Divaldo, this was great and very educational. And I think we should definitely have you back to do your other cases and maybe bring some more in the future.
Sure, class.
That was really great, Divaldo.
Thank you, Chris.
Okay, I'm going to share my screen here. And is Raj on the line? Oh, sorry, my bad. I have not yet given him speaking permission. Can you do that, Peter? Because I've got the full screen up.
Okay, just did. You should be able to talk now, Raj.
Okay, thanks very much, guys. I just want to give an update to our department. Last night, Dr. Betterson was awarded the Jacoby Medallion, which, for those of you who don't know, is probably Mount Sinai's highest honor. It's given by the Alumni Association. It was started in 1952, and it was actually through Dr. Jacoby, who was president of Mount Sinai and president of the AMA, actually, and considered one of the founders of Pediatric. So it's an esteemed honor. Obviously, if it wasn't for COVID, there would have been a ceremony and we would have had a reception as well. I think it represents not only academic achievement, but service to the whole community. So it's yet another amazing accomplishment for Dr. Betterson. He had the endowed chair last year, as you all know. So I just want to recognize Dr. Betterson and thank him again.
Thank you, Raj. If you stick around long enough, some of these things come, and if they come, it's only because of a department like this one. It just keeps getting better. Presentations like we had today, they're just at the top. They're just at the top. So I really appreciated the award, but mostly appreciate being at a place like Sinai and working with a department like you all. Thank you.
Now get rid of this screen, please.
Peter, you're muted.
Thank you. So Praveen Raju is a physician scientist here at Mount Sinai. He joined us last year. He completed his undergraduate training and medical training at the University of Pennsylvania, pediatrics and neurology training at Columbia and Boston Children's Hospital, and a postdoctoral fellowship at Memorial Sloan Kettering Cancer Center, and then started his career at Weill Cornell in child neurology. He truly is a triple threat. So on the clinical side, he is a child neurologist who specializes in neurological complications of cancer. He, on the research side, developed a novel mouse model of sonic hedgehog medulloblastoma and is currently studying nanoparticle delivery to tumor endothelium, and has multiple NIH-funded projects in his history, including a current R01 grant from the NIH. And on the education side, he was the Associate Child Neurology Residency Director at Weill Cornell and is now starting a child neurology program here as program director. He is a phenomenal and enthusiastic colleague, a skilled clinician, and on a personal note, he was actually the first attending that I had the opportunity to work with in child neurology when I was a third-year medical student, and I am grateful to him for that. So welcome, Praveen, and we're looking forward to your presentation.
Great. Thank you, Peter, and the department for the opportunity. Now, when you say that, it makes me feel old, but I don't think we're that old, Peter. You know? So let me just share my screen here. Not that being old is a bad thing, wiser, I should say. Where's my screen share?
Yeah, it is. It's pretty bad.
All right. And are you able to see?
Yes.
Okay. And is that okay for you guys?
We're seeing your presenter view.
Oh, got it.
Instead of the full slide.
See if I can help that. Should you just, that's probably, you know what it is. I got it. Here we go. Apologies for the delay. Should have rehearsed this. I'm not as wise as I thought. Is that clear, or is there another? I have two screens.
Showing us the main desktop now.
Screen, unfortunately. Now,
If you change your screen share, it may give you the option of sharing your other desktop.
Just hit screen share. It only gives me one, so but I think the pictures you'll see are quite big. I hope.
Yeah, no, that's it. You can do it in that view. That's fine.
Oh, actually, this might be better.
That works.
Okay, all right. I think that might work. No, okay. All right, so let me just get started. I know in the interest of time. So I hope I'm a pediatric neurologist, but I study pediatric brain tumors. But I hope the principles that I'm going to talk about today are actually applicable to beyond medulloblastoma, which is what I focus on, and other pediatric brain tumors, but really brain lesions in both in all age groups. Just as a disclosure, I'm an unpaid consultant to a startup biotechnology company that works on cancer, not necessarily gliomas, and I won't be presenting any of the work that they do. So the ultimate problem, I think, when I got into this was, you know, we have lots of labs and research groups around the country and have really exciting work that's been done in all kinds of models. But what ultimately happens is when we try to translate this to patients, we have a really poor success rate. And I thought the way that I wanted to approach it was kind of using the hurdles that many of us are well aware of in cancer biology. If we can actually accept them and then try to achieve things above those hurdles, maybe we might have a better chance. And so what I call are the elephants in the room. And this applies really to all of cancer, but one of the biggest ones is cellular and tumor heterogeneity. Every tumor cell is not the same. And if we assume that every tumor cell is the same, I think, you know, non-specific chemoablative or high dose chemotherapy or radiation should work if you can achieve high enough doses. Unfortunately, the problem is the body has cells that are very similar to human cancer cells, and therefore we're often limited, and then the heterogeneity question becomes really into play. Are we really hitting every cell? Many of us, as you know, metastasis is the real problem. When a tumor migrates away from its primary site, are those cells the exact same as the cells at the primary site, and should they have disease or site-specific molecular therapies? And we don't really have a lot of information in the literature that really shows that. We try, but we don't often resect the metastatic lesions. And then the real problem, I think, is that we've done really well over the last 50 years or so in terms of chemotherapy and radiation protocols. But upfront therapy, when we reach, in the case of a lot of pediatric tumors, brain tumors, we're up to 70, even 80% survival rates at 5 years. The problem is the ones that do really poorly, when those tumors come back, we often assume that they're the same. And then we use a lot of information from the primary tumor resection and therapies at that recurrent setting. And often I think that's one of the main reasons that a recurrent tumor is very poorly treatable. And then for the specific case of brain tumors, this whole concept of how do you get things past that blood-brain barrier. So to summarize, really the concept in a very simplistic diagram is that all cancer cells are not the same. So there's some that are molecularly different from, like, for example, these yellow ones compared to these gray ones. A tumor microenvironment, including immune cells, microglia, tumor-associated macrophages. The endothelium is actually different in a tumor as compared to maybe normal endothelium in adjacent tissue. And then the concept that migrating cells are actually the same. So I think that heterogeneity really needs to be appreciated. And in the setting of GBM, this is data that's almost 12 years old now. When you take bulk analysis of tumors, you can actually subdivide them or categorize them as to what are common molecular drivers between tumors. And this study showed that there are at least 4 molecular subgroups: proneural, neural, classical, and mesenchymal, as you've probably heard of over the years. And people have associated alterations with these subgroups, such as, for example, the classical has EGF receptor molecular alterations, the mesenchymal has NF1 related molecular alterations, or the proneural with PDGF. But the reality in GBM, this paper from MGH Neuropathology almost 10 years ago, when you take regions of a GBM, either at the primary site or at migrating sites, this is triple fish for some of those molecular markers that distinguish those subgroups. You can see that the red here, EGFR, is in some cells in this region, for example, and in other cells right next to it are PDGF receptor amplifications. And even you'll see some examples, it may not show up very well, but even in some cells, you'll get the same alteration in the multiple molecular alterations in the same cell. So I think unless you really get down to tumor cell, single cell heterogeneity, which is, obviously quite complex, I think we do the best we can, but that limits our therapeutic options. And then we know we do a great job, the surgeons, I think, get 99.9% of this tumor out. And it's often that last 1% or less that we are trying to clean up with chemotherapy and radiation. The problem is when you do that in a kind of a brute force type of way, when recurrence happens, often it's unclear which of these molecular subclones are the ones that come out at recurrence. Is it something within the primary tumor? Is it a clone that was going to be metastatic that really is resistant, or one of the others? And people have tried at least targeted therapy. This is actually adult sonic hedgehog medulloblastoma, a PET scan looking at tumor metabolism. And this was a science paper from about 10 years ago where this is, very rarely medulloblastoma metastasizes outside of the central nervous system. But when it does, you can see some of these multinodular lesions, often in the bones. Using a sonic hedgehog specific inhibitor, you can get very dramatic responses 2 months post-treatment where most of those lesions have disappeared. But as is the case with most targeted therapies, in this case, only a month later, everything comes right back and is refractory. And the general rule has been in single agent targeted therapies for cancer in general, you get about 6 months to a year before recurrence happens. And then you're kind of stuck. So I kind of always wonder, like, how do you, is it because of the way we're doing this? And it's a really complex problem, but I think what we tend to do is we get data, treat what works, and then when something happens, we use data from that primary tumor and we hope that it works again. But what we're really doing is chasing the tumor. And the tumor, and I've always, whenever I've given this talk and gotten into cancer biology, it really lets you know how smart Charles Darwin was over 150 years ago about evolution. But here at the molecular level, when we put selective pressures such as radiation, chemotherapy, targeted agents, these tumor cells want to live and they find a way around it. And so the real question that I always want to think of is, are there ways to come and be ahead of that trajectory? This is the paper, a Nature paper from Michael Taylor's group, a pediatric neurosurgeon at Sick Children's in Toronto. And he actually did the experiment where he took 40 medulloblastomas at a primary diagnosis. And in the same patient, he took recurrence samples, did whole exome sequencing, and asked either in the primary shown here in red or in the recurrent sample in blue, how many of the molecular alterations are retained. And his basic conclusion was it was on the order of 10% of whatever was in the primary tumor molecularly was retained. 90% is gone. And when you compare those 40 individual tumors, there's not really a common link between all of them. It's not like they all evolved to the same recurrence pathway. So unless we as neurologists, neuro-oncologists, and neurosurgeons are willing, at least in brain tumors like medulloblastoma, rebiopsying lesions or finding biomarkers in a non-invasive way, I think we're kind of aiming, blindly at a dartboard, especially at that recurrence setting. And this paradigm has actually been shown molecularly for other neural tumors such as neuroblastoma and blood-borne blood tumors as well. But here's what we do in many of our clinical trials. We get that molecular information, and then when we enroll them, they're at recurrence often. So one approach that we decided to take was, are there ways that we could find adjuvant therapeutic approaches that we can add on to current standard of care so that you're not giving up that standard of care up front, but maybe you can at least preclinically show evidence that throwing adjuvant approaches could enhance or improve outcomes. And one significant point about that is, again, to try to stay ahead of the tumor, because most of us have molecular information from the primary tumor. If there are ways that we can model tumors in preclinical animal organisms, if there are ways that we can identify post-standard of care therapy, essentially minimal residual disease, if you will, that's the population of cells that you'd like to add on therapies to. And the problem, I think, highlighted by the slides before, is that bulk analysis is going to limit you. The key is to really treat, get to that minimal residual stage. If you can identify those tumor cells, usually by some fluorescent marker, and now that single cell omics and analysis has gotten to a much better resolution, now use that information preclinically to then add on therapeutic trials, preclinical therapeutic trials. So that ideal model, I think, for sporadic cancer, which applies to brain tumors as well, is that from a field of cells, if you could create a model where only one or a few cells are mutant or cancer promoting alterations, and you can lineage trace it with a marker that allows you to follow it over time, you can study it in a way that either at early initiation stages, intermediate stages, if it ever leaves that primary site, metastatic alterations, to actually ask, are they molecularly different or not pre-therapeutically? And then post-therapy, if any of those green cells remain, then can you ask what's different? Is it just because did we not give enough therapy? Versus is it actually that target is not there anymore? And you can, now that these single cell omic approaches, everything over the last several decades has allowed us to study those cells in isolation and do all the standard biochemistry and molecular biology that we typically have taken advantage of from bulk analyses. So the way I thought was, why do you even need to make a brand new model or a new model of cancer. And I think it's that failure rate. About 95% of all cancer drugs that we go through the whole FDA process just don't make it all the way through. When I started just only 10, 12 years ago in this, the cost was about $1.2 billion to get through the whole process. Now it's almost $2.4 billion. And with a 95% failure rate, you can imagine that's a quite expensive endeavor. And then of the ones that succeed, if you're only getting 6 months to a year transient benefit, it really puts into the paradigm of the approach. So our approach was, could we find a model system or develop one that can take advantage of features of human tumors that are unique to humans that are not captured in simplified model systems. And just some examples of that are, I'll go into a little more detail with sonic hedgehog medulloblastoma, but at least there are 4 major molecular subgroups, and you can profile those as soon as you take those tumors out of the operating room, and with some immunohistochemical analysis, group them into the 4 types: Wnt, sonic hedgehog, group 3, and group 4. But what happens is, as soon as you put them in a plastic dish, very rapidly, they all come to a very homogeneous cell type, at least by those markers. And it's not within, over several generations of passages. It's actually quite quick and within 2 or 3 passages. So one concern, and this paper is about 5 years old, but this actually applies to many cancers. A very nice paper from the Broad Institute from Todd Golub's group in 2018 in Nature showed that even cell lines as well as PDX models molecularly change within 5 passages. And you're probably really what you're doing is studying a subclone within that tumor. And so unless you have enough model systems where you have all the subclones or a nice majority of them included, you're going to be limited. And again, I don't want to dismiss any of these model systems. I think that's the best we've had, and I think that's the current state, but I do want to highlight those limitations. And one of the things that always troubled me was xenograft models, especially for brain tumors. You can imagine putting a human brain tumor cell or cell line under the skin of a immunodeficient recipient mouse. What will happen is the vasculature and the nutrient supply of the vasculature allows these tumors to grow at a certain rate. And what you'll typically do is measure them once they get to a certain size by using calipers, use an agent, and then your assay endpoint is does it not grow as fast as the one that you've seen there? And you can imagine that this is going to be destined to fail in the clinic. You haven't killed the cells, you just made them grow slower. So if that's sufficient enough to give you a therapeutic benefit, that's fantastic. But many times they fail because it isn't sufficient because you're studying that subclone or a few subclones. So we use genetically engineered mouse models. And over the last 25, 30 years, when genetic engineering in the mouse was started, it was still, a brute force kind of approach. The general way was, if you had a tumor promoting oncogene, you could transgenically introduce that oncogene in every cell of the mouse. And if that was sufficient to cause a overgrowth phenotype in some tissue, you had your model. And if you can be more selective and say, I'm going to make that oncogene selectively in a brain or some part of the brain or other tissue, you're still dealing with millions and millions of cells at those initiation stages. And the limitations of those approaches, whether it's an oncogene or loss of a tumor suppressor, is that many of these models tend to use approaches where you are often knocking out tumor suppressors like P53 or RB or P10 that don't, because those are the tools that we had, are used in these settings, but they're not necessarily the molecular alterations that you find in human patients or in the same context of the tumor promoting. So you can imagine if you do the right thing with high enough doses of anything, you can make things change. And I think that's limited what those models do. For example, breast cancer models sometimes need to take out 3 tumor suppressors to even get a 40% penetrance of the tumor phenotype. And then even rarely, they might even metastasize, whereas we know many models metastasize much more readily. But you'll never see at initiation stages 3, 4 tumor suppressors knocked out at the same time. So we thought that if we could, in a mouse organism, which was at the time the most sophisticated mammalian model organism for genetic manipulation, whether you could, in a few cells or a cell, ideally, if you could make an alteration and then keep the rest of the organism, including the immune system in that mouse, normal, you can actually study this in a way that, it's a lot of what ifs with, and it takes a lot of time and work. And I think 10 years got us to a point where we got a little lucky, used a lot of the information that many have employed studying the tumors medullos that we study, and then learn from those to see if we could optimize it. And as you can imagine, the widespread recombination or mutagenic approaches are more like hereditary cancer syndromes, which are very rare. And really most of what we deal with are really the sporadic cancers. So the basic premise, I think, is that of our approach is that we think individual cells will behave differently, either during the evolution of their tumor progression based on the selective pressures that they and their neighbors exert upon each other, or in the setting of selective pressures. They won't all behave the same. They might in a tissue culture dish because you can control for that a little more. But I think in an in vivo organism, it's a little different. And so we wanted to appreciate that. So I'm going to get a little into medulloblastoma just because I know it's a tumor that most of the adult neurosurgeons are familiar with, but maybe not as much as Peter and Sadi. So for years, leukemias were the most common pediatric cancer, leading cause of death. And about 3 or 4 years ago, unfortunately, brain tumors in children are now the leading cause of death. They've always been the most common solid tumor of childhood. About 4,000 kids a year in the US are diagnosed annually, a little over half of which are considered aggressive or malignant. It's primarily a tumor that arises in the cerebellum, in the posterior fossa. About a third of patients, despite whole brain and spine radiation and adjuvant chemotherapy, still succumb to the disease at 5 years. The 2/3 that do survive have very significant treatment-related comorbidities. For example, 20-point IQ deficits, endocrine issues, growth issues. And then if they can make it, the 10 or 15% that tend to go from, another 10 or 15% go up to 10 years before they pass away, they actually tend to get gliomas and other secondary malignancies. When a medulloblastoma relapses, it's over 95% poor outcomes. And this accounts for actually about 10% of all childhood cancer deaths. So medulloblastoma is actually on a gross level divided into 4 molecular subgroups. The Wnt-driven subgroup is a developmental signaling pathway characterized by activation of that pathway. A third of them are activated by the sonic hedgehog signaling pathway. And then 2 groups that are less well defined by a single pathway, but they molecularly classify separate from Wnt or sonic. The reason we focused on sonic hedgehog is that about 25 years ago, Matt Scott's group at Stanford developed the very first model of medulloblastoma where he knocked out the patched tumor suppressor gene. It's a part of the pathway of sonic hedgehog signaling that if you lose it, it's the gene that's altered in Gorlin syndrome, which about 10% of those kids tend to have medulloblastomas among a few other tumors, rhabdomyosarcoma. So we thought we would build on that. But the problem with those models is that you can mutate the patched tumor suppressor in every cell of that organism. Only about 10% of the mice get a tumor. And it takes about 6 months to a year to actually develop that tumor. So you can imagine it's a highly inefficient process, and with the lack of resources and funding to study this and time, it took a lot of years to really show that what we could learn from it, but also what the limitations are. But the most important thing is that in humans, medulloblastoma, the sonic hedgehog group, is actually histologically diverse. It's not homogeneous. In fact, about half of the kids have the classic round blue cell. It's a neuroepithelial embryonal tumor, very proliferative. And then this is not the same magnification, but about half of sonic hedgehog-driven medullos have a differentiated, what's called a nodular desmoplastic. So with the darker hematoxylin staining nuclei, proliferative, that tend to surround these pale neurocytic differentiated tumor cells that are these that define it. Importantly, just because you have this pathway active, they all get the same therapy, but what happens is about 25 to 70% of the classics actually have a good prognosis, 5-year survival. The reason that it's typically 50 to 70, but if you're P53 mutant, you tend to be on the lower end. However, almost 90% of these nodular desmoplastics do very well. So it begs the question, why are we giving everyone exactly the same radiation and doses and the same chemotherapy when these guys do so well? Can we get away with less? And when you look at all of the mouse models to date, by the time we got into this, there were over 20 models of sonic hedgehog medulloblastoma. All of them only give you this one histology. So that was a limitation. So we needed a better model. And a paper in Cancer Cell around 2008 or 9 tried to ask the question, what's the cell of origin of sonic hedgehog medulloblastoma? And what they did is they took the patch tumor suppressor gene and they knocked it out in various cell types in the cerebellum, either in the progenitor cells of the ventricular zone using certain Cre drivers, in the neuronal cerebellar granule neuron progenitors throughout the whole developing cerebellum, certain within regions of that EGL or external granule layer, or posteriorly. And at the end of the day, they all look the same. They all look classic, and you couldn't really molecularly define them in terms of differences. And you can imagine, you don't have to be a neuropathologist or a specialist, but to think that these two histologies are molecularly identical would probably be a little naive. So we thought that that was a good starting point. So to disprove this theory that the cell of origin, there was some technical aspects of these studies that I can't get into, but it was really some of the Cre mouse genetic drivers that they use. They're kind of a little dirty or leaky. So we thought if you really wanted to prove that the cell of origin was the external granule layer cerebellar granule neuronal progenitor, to use a driver that is leaky, for example, the human GFAP Cre, it doesn't only recombine or make mutations in the ventricular zone. There's actually mutations that happen out here as well. So we thought to address this, we needed a specific driver that was so specific to these cells and show that it never forms a tumor, and that's the real answer. So it was kind of the null hypothesis approach. And we did that, and again, we got lucky because it wasn't what we actually expected. We ended up finding that these tumors, almost all of them, this is a control mouse, a heterozygous control. This is a sonic hedgehog-driven tumor mouse. You can see they lose weight. They kind of have a domed head. They become ataxic. And about the last week or so of their life is when they become symptomatic. And when you look at them at a gross pathological level, the heterozygous controls, you can see the cerebellum here. You get this tumor that looks, it's growing on the very surface of the cerebellum. And it was really peculiar to us because we didn't expect this to form a tumor at all, but it did generate a very efficient tumor model, and I'll explain why this really opened our eyes to a lot of things. The tumors occur in about 85% of the mice, so we don't have to rely on 9 out of 10 mice spending money that they don't help us out. And then the latency was not 6 months to 12 months. It was in about 3.5 months. So they were faster and they happened more often. And when we molecularly analyze them, this is RNA-seq gene expression analysis. The tumor model shown here in this light blue groups along the sonic hedgehog group and not along the Wnt or group 3. And this is just a very specific look at the sonic hedgehog classifier. Our tumors are very right in the middle of that group. And the reason for this is that when you look over time for when these tumors form, this is H&E staining of the cerebellum in a developing mouse at postnatal day 2, 7, all the way up to 4 weeks when they start reaching weaning and maturity ages. The external granule layer, the cells on the outside of the cerebellum, the cells of origin, they proliferate for a few weeks, up to 2 weeks, and then they differentiate and occupy cells within the internal granule layers, differentiated neurons. But what we were finding was these rare sporadic hyperplasias that were forming in the anterior cerebellum, which is what in humans, 2/3 of medullos are hemispheric. Sonic hedgehog medullos are in the hemispheres of the cerebellum, and they're in the anterior. And so this was the regions that they would be forming. And then the fact that they were forming from these areas, I can't show you all the data, but we can use genetic fate mapping to show this Cre driver. there were these less than 1,000 cells that were uniquely expressing this gene right there. And those were the cells of origin. Everything else is normal. And that's very different because you can get a tumor where if you started with just only less than 1,000 cells, you get these tumors very efficiently. If you made every cell on the outside of that cerebellum mutant, what happens is that you get a tumor, but you actually get like probably hundreds to thousands of tumors all within the organism. And they're essentially different tumors. And so how do you ever study resistance or recurrence? You know, because if cells remain, which tumor did it come from? And very uniquely, as I mentioned, every patient with medullo has leptomeningeal metastases. Every mouse model to date prior to this actually did not. In fact, there were only 2 of the roughly 17 mouse models at the time the slide was made that even showed leptomeningeal mets, and it was very low in the model system, 2% of their mice. And this is our model. We found that 92% of our mice actually had leptomeningeal mets. Remember, the tumors start over here. Here's another little met here. And this is just zoom in H&E and molecular analysis of cerebellar progenitor markers that should not be in the leptomeningeal space. So this really allows us to study now from these very few cells that form, leave the site, they actually end up being GFP positive. So we can lineage trace them. When we treat, we can ask, does it only this primary tumor that disappears? Do these also get affected or not? And we can actually do things like that. So the first question we wanted to ask was, well, why do these tumors even form classic histology, round blue cell histology versus this nodular, as I mentioned, and they have different prognosis. So we took a technique that we developed, a collaborator of ours, Dan Turnbull at NYU, he used a small animal micro MRI approach known as manganese enhanced MRI. So these are actually mouse MRIs on a 7 Tesla magnet. And what you can do is 24 hours prior to imaging, he tends to do a lot of neurodevelopmental studies. So we thought that could we use this for tumor modeling? 24 hours prior to imaging, if you use a subphysiological dose of manganese chloride, you can get some structures in the rodent brain that enhance on T1 weighted imaging. The hippocampus, the olfactory bulbs not shown here, and the cerebellum. And this is a normal mouse. These are 3D reconstructions. And you can see this negative contrast enhancing lesions, these hyperplasias that are growing in the hemispheres, primarily anteriorly. And then if you follow this, the same mouse over time, you can see that those 1,000 cells tried to become tumors, but most of them eventually just didn't have what it took. Patched is not sufficient. You need other molecular alterations. And almost every mouse, only one clone really drove and became the tumor. So it really shows that you can follow this over time, and then you can also follow it after treatment. So what we did is we did 3D volumetric measurements of the tumor that grew. Each of these lines, this is volume of tumor over time. These guys get sick around 3.5 months, so almost 12 to 16 weeks or so. Each line is, we found that the volume of a single mouse, we found some mice that were fast growing versus slow growing. Non-invasively, we had no histology. And then when we actually got symptomatic and looked at them, the fast growing tended to correlate with the round blue cell classic histology, and the slow growing tended to grow with, associate with this nodular desmoplastic slow, which makes sense. You're more proliferative, you're less proliferative. So we have now, I think, a way that we can identify classic histology sonic hedgehog medulloblastoma and nodular non-invasively in a preclinical setting to ask if we wanted to treat now before these tumors, before we have to sacrifice that mouse, do we have to give the same dose? Can we use dose reduction strategies here and then use that data for preclinical trials? Because everyone's obviously scared to dose reduce for something that works almost 90% of the time. And we can hopefully spare some of those toxicities. And when you look at those tumors, actually what we showed is that 3/4 of our mice, not 50-50, were these classic, this is immunohistochemistry for Ki67 proliferative or NUN, which is differentiated neurons. 3/4 were classic histology. And you can see it's not just a little tiny patch of the tumor. It's all the way throughout the tumor, this nodular desmoplastic histology. So we think we have a really robust model. And this is just a close-up showing you that these nodular regions are proliferative, Ki67, the nodulars are not proliferative, NUN in the middle, and then we can lineage trace because the GFP lineage tracer that ties to proliferating tumor cells and sonic hedgehog signaling actually sticks with the proliferative cells. They all started proliferative, but something happens. They convert from this Ki67 positive to negative. It happens late. We actually looked, that's not an early event. When you look at the survival of these mice that are either the classic histology or the nodular, it's the Kaplan-Meier survival curve, you can see that actually that as expected, the most proliferative ones, they tend to die sooner, and the nodular ones, and this is quite significant. So we actually have a baseline to now do dose reduction and therapeutic trials to then ask, do we alter these tumor survival phenotypes? So we wanted to ask, well, does our model really look like human medulloblastoma? So this is sonic hedgehog nodular desmoplastic medulloblastoma human. You can see this is H&E showing the nodular surrounded by Ki67 proliferative regions. And you can actually do something where you can stain these FFPE sections with toluidine blue. And it nicely demarcates actually the nodular regions from the proliferative regions. And I'll kind of cut to the chase. It ends up that one of the molecular drivers, when we did when we did RNA-seq expression analysis between these regions and these regions in human, it ends up that epigenetic alterations were the main pathway that distinguished why a hedgehog medullocell is different than a non-proliferating hedgehog medullocell. And it ends up that EZH2, which is part of this PRC2 complex, an epigenetic driver driving mechanism, is uniquely expressed in that proliferative population. There we go. This is the RNA-seq gene expression when we took laser capture microdissected nodular regions from those primitive regions of the same tumors. And there's about 112 genes that were uniquely different. And when you do gene pathway ontogeny or pathway analysis, those 112 genes that distinguish these two groups tend to correlate with PRC2 or SUZ12 epigenetic differences, and essentially differences at the level of histone 3 K27 methylation, which you probably from adult glioma work and DIPG work is an important distinguisher of certain glial tumors as well. It ends up that EZH2 is high in lots of tumors, not just brain tumors, but epithelial tumors. It's it's a way to basically inhibit differentiation. So when you ask the question, it gets a little more specific, but medullos, you can divide the Wnt group into 2 specific subgroups, the hedgehogs into 4 specific subgroups, and so forth. And EZH2 compared to normal cerebellum is high. So how do you distinguish this? But what I want to point out is people actually spent the first, it's always like the low-hanging fruit, I think. They went after the ones that were at the time the hardest to treat, the group 3s, and they saw that they were mostly the highest. So they tried to do these approaches where they would genetically block EZH2 with RNA interference, or in vitro, they would use inhibitors. And what actually happened was you actually made the tumors grow faster. It actually was not a tumor suppressor. It was actually EZH2 acted like a tumor, an oncogene. Actually, there was a study almost 10 years ago in GBM cells in vitro similarly that if you blocked EZH2, initially you get a transient growth arrest, and then they just became super aggressive. Now, is that acquired resistance? They haven't really looked at. The point I want to make out is in this hedgehog group, this one group here that's really low relative to the others. And this is adult hedgehog medulloblastoma. This is there's 2 infant subtypes of medulloblastoma, and the one that has the nodular desmoplastic histology is this group here. So I wanted to make the argument that it's not that it's high, it's that there's something relatively low here, that the threshold to differentiate is a little easier here. And so could we manipulate that? And that's the basis of the remaining part of the talk. So we need to ask actually then from our human studies, is EZH2, is it recapitulated in our model similar to what we found in that human laser microdissection studies? And now this is our mouse model. When you look at EZH2 expression in green, immunohistochemistry, and NUN, those differentiated areas within the tumor regions, you get these proliferative Ki67 regions that are surrounding these nodular NUN. So it is similar to the human. And the target of EZH2 is H3K27. It's the methylator that methylates here. And that ends up being in the same area. When you take nodular desmoplastic tumors in the mouse and you do single cell RNA analysis, these are almost 90 to 95% tumor cells, a little immune tumor microenvironment here, some astrocytes, some oligodendrocytes, some nondescript cells. But it's almost 90% is all tumor. There's a very little microenvironment. But you can see that at the single cell level, there's either EZH2 high and EZH2 low regions. And again, consistent with our protein level immunohistochemistry. So we did a very simple experiment. If this is really important, we knew that 3/4 of our mice had classic round, embryo round blue cell histology, and 1/4 had nodular desmoplastic. So we genetically removed EZH2 from those initiation stages. And what we found was, here's the normal cerebellum. We got this widespread neuronal differentiation within the tumor. So if you can kind of imagine, green is go proliferative, red is stop differentiated. This tumor is essentially, it still grows because as I showed you, they get tumors, they just get it later. So I think this role is really a later event, but you get this massive widespread differentiation. And we can convert all of those tumors from a very faster, aggressive embryonal tumor to a less aggressive differentiated tumor. And when we looked at molecular markers, these are parts of the sonic hedgehog signaling pathway. This is cyclin D1, and these are CDK inhibitors, cyclin-dependent kinase inhibitors that are anti-proliferative, if you will. And we saw when you knocked out EZH2, you block sonic hedgehog pathway, you block cyclin D1, and you actually get an increase in these CDK inhibitors very specifically. And so we thought, well, if that's really real, can you now then take away P16, which is this inhibitor, which is thought to be, has been shown in other studies to be downstream of EZH2, and we can actually convert them all back. And this is an old slide. We actually are up to about 25 mice now. So this paper is almost out, but we think that at least at the molecular level, we can, genetic level, we can manipulate the differentiation capacity of this tumor to then get, to maybe have some therapeutic effect. And we thought, is this unique to all anti-proliferative CDK inhibitors? There's lots of them more than here, but P16 and P15 are shown in these two panels. P18, P21, and P27 are here. It actually ends up unique to this locus, where if you have EZH2 knockout, you actually increase P16 or an anti-proliferative effect. And if you have a gain of function allele, genetically, if you have a constitutively active EZH2, you actually then inhibit that. So we think it's consistent. And it finally tied in with like data I've had for like sitting on my desk actually for about almost 8 years. We actually took our medullos that were nodular and we did senescence associated beta gal activity. And here's normal midbrain here. And we found that there were these nodular regions of essentially senescent cells. And I think what these nodular areas for the first time are not differentiated tumor cells. We think they're senescent. And it's actually a tumor intrinsic tumor suppressor system that these tumor cells are using. And because we can still use it, maybe we can therapeutically use it to our advantage. And so when you look at the survival of, as I mentioned, the classic medullos to the nodular desmoplastic, which are less aggressive, the same Kaplan-Meier survival curves are here. If you take away EZH2, you basically, all the tumors, again, become nodular and they actually become less aggressive compared to heterozygous controls where about almost 3/4 are aggressive and maybe just by chance that 25% tend to be not. So we think there's a therapeutic effect. But those of you that might know, EZH2 inhibitors have been around for a while now. They don't get into the brain. So Epizyme, GlaxoSmithKline, they all have variants of this and it's well known. In fact, they'll tell you, don't try it in the brain. So how are you going to get it past there? And I'm going to spend the last 10 or so minutes up until 9 o'clock to show our efforts of how we've been trying to get drugs past the blood-brain barrier and then tie back into EZH2. I'm sorry for the top here. So I'm not going to go into detail, but as you know, the brain, blood-brain barrier is a much tighter barrier with not just tight endothelial cell connections between the cells. There are also GFAP positive astrocytes, microglia that all have end feet and contribute to this barrier. And it's a protective mechanism, obviously, for toxins and infections that so that we can cognitively still function. Very different than endothelial barriers elsewhere in the body. So about 5 years ago, Richard Gilbertson's group, he's now at Cambridge, he was at St. Jude's at the time, showed that there was a difference between hedgehog-driven medulloblastomas and Wnt-driven medullos. And I didn't mention this, but Wnt-driven medullos actually have a very good prognosis, 95% survival. We actually were doing some studies about it, and I think Richard actually was also working on it, and he saw a poster of ours. We found that we actually realized that hedgehog signaling was never in a Wnt tumor, and Wnt signaling was never in a hedgehog tumor. And in fact, there are developmental mechanisms in the spinal cord and the cerebellum where there are antagonistic signaling pathways to help pattern nervous system structures. So we thought, well, could we use a way to activate Wnt? There are Wnt agonists such as lithium and so forth, and genetically you can do that with stabilized metacatanin into these tumors. So we actually, in our own hands, we drove Wnt signaling. We kept getting these very hemorrhagic, bloody tumors, and we never finished that. That story's still in progress. We haven't finished it yet. But then Richard published this paper where he used this is a blood-brain barrier assay using TMR dextran, where you can inject it intravascularly, and then you can look into the tumor to see if it leaks out. So it ends up that hedgehog-driven tumors have a very, very tight blood-brain barrier, and they tend to not have a great prognosis, whereas Wnt-driven tumors have a very leaky blood-brain barrier, and this is where the tumor is actually. And this is just at the histological level, the difference between the Wnt, and it's not because the dextran doesn't get through it. You do perfuse those areas. It's just that, and it ends up, the reason is because the vasculature in Wnt-driven tumors is slightly different than other brain vasculature. So we asked in our own model system, does this actually happen? So this is our mouse model. We injected TMR dextran, and initially when we perfused the mice, we weren't seeing any TMR dextran. It's because we were just washing away the TMR. So this is unperfused to actually capture the TMR dextran within the blood vessels. This is CD31, just to show you where those blood vessels are. And I wanted to highlight why we got into this, because it ends up that P-selectin, which is an platelet and endothelial selectin transmembrane receptor, also was uniquely expressed in these tumors. And a colleague of ours at MSK, Dan Heller, was working on these nanoparticles that were based on a sugar known as fucoidin. And he was studying tumors below the neck. And what he was showing that he could encapsulate drugs, and he could deliver drugs to tumor vasculature specifically, and it could be enhanced in the context of radiation. So when I heard this talk about 2.5 to 3 years ago, there was a paper in 1998, actually. This is Doug Hanahan at WashU, had a rat C6 glioma allograft model. If you radiate it, what he found was the only point of this paper was that the glioma tumor-specific vasculature, the endothelium, upregulated P-selectin in a dose and time-dependent manner, but the normal brain vasculature did not. And if you will recall, P-selectin is something that inflamed endothelium it overexpresses, and leukocytes, the ligand for P-selectin, PSGL, can detect that receptor, slow down, and that's how they intravasate into inflamed tissue to do their immunological functions. It ends up that fucoidin looks a lot like PSGL and that ligand for P-selectin, and it's a sugar from brown seaweed, actually, organic, but it has a nanomolar affinity to P-selectin, and you can actually use it as a structural element for building nanoparticles, which are based on essentially hydrophobic interactions. So what you can do is you can take a lot of drugs, including not just the sonic hedgehog pathway inhibitor, which I'm going to tell you about, but chemotherapeutics, paclitaxel, doxorubicin, vincristine. We've done a lot of these. You combine it almost as like a cookbook. You just kind of mix it in certain ratios, and it's just a self-aggregation assay based on hydrophobic, with like a dye in a very low percentage, which is similar to indocyanine green, which is used as an FDA-approved agent for diagnostic radiological procedures. And you can create a nanoparticle that's about 80 nanometers that has this drug, that has the capability to target P-selectin, And you can make control nanoparticles with dextran sulfate, same size, that don't have the p-selectin targeting capability as controls. This is atomic force microscopy showing that these fucoidin hedgehog pathway nanoparticles are relatively homogeneous, about 85 nanometers in diameter. This is diffusion light scattering microscopy to show that, you know, when we make these, it's not that we get some tiny ones that might sneak through. They're all within this size range. And they're quite stable. So this is, again, diffusion light scattering microscopy looking at nanoparticle size over time in deionized water as well as in serum, and they maintain their size. So they're quite stable. Okay, so we need to ask the question, well, does p-selectin upregulate in our own model? So this is immunohistochemistry in our hedgehog's medullos. Non-radiated p-selectin, there's very little, but there is some basal level in the vasculature. Here's CD31 showing you where the vasculature is. If you give 2 gray, which is the standard fraction, you can actually upregulate it in the tumor, and it co-localizes with the vasculature. And importantly, this is the adjacent normal midbrain. It does not get upregulated. So you have now a way to hone these nanoparticles to your agent, to your area of interest. And very cool, I thought was cool is that it didn't have to be 2 gray. We worked our way down, and as little as 0.25 gray also enhanced it. So again, for dose reduction or adjuvant therapy approaches, even at recurrence, you might have this opportunity.
Just a quick reminder, Praveen, we have a few minutes left.
Okay, no problem. And so this is just a Western blot showing that it's time dependent, and we quantify that. And to actually ask if they work, that IR dye, this is how we can trace these nanoparticles. If you don't radiate, you get it into the tumor. There's actually a little hemorrhage here. You can see that the nanoparticles essentially stay within the vasculature. But if you pre-treat 2 hours with 2 gray, you get this massive influx. And this is within 6 hours time. So way before the blood-brain barrier even breaks, and we have data it doesn't break down. So we can localize tumor to where we want. If we inject it in the absence of any radiation, you can see that I hope it shows up, it stays within the vasculature. We can get the nanoparticle to the brain. That low basal level of p-selectin on non-radiated, we can get some tumor drug there, but it stays there with radiation, now a lower dose, markedly enhanced. And using those controlled non-p-selectin targeted molecules, it does not enhance. And this works with very small tumors as well. Here's a gross of a very large tumor, non-irradiation. You get a little haziness that shows it's localized, but this very tiny tumor, you can actually get it to where you want. And we asked the relative amounts of cerebellum or tumor to forebrain, and we get about a 3 to 4-fold increase of tracer to forebrain. And then when we do mass spec analysis of the actual drug in the forebrain to cerebellum, we can actually detect the drug very uniquely in the tumor. I'm gonna highlight through this. When we now test with the downstream target of the drug, the GLI1 signaling pathway, this is qPCR, we find that it's in a dose-dependent way and synergistically with low-dose radiation and very low doses of this drug. Normally you need 100 mg per kilo. So this is 10 to 20 milligrams per kilo. And the control nanoparticle that doesn't target has no benefit above radiation. And then when we work our way down to very low doses of radiation, you can see that even now nearly 1/10 the radiation, nearly 1/10 drug, you get about an 80% reduction. And survival, rather than treat mice very early, we waited till they were very sick in the last week of life. If you don't do anything to them, they die in about 3 or 4 days. We gave drug. If you give radiation, I should say, a total of 2 gray fractionated doses every other day, you can get some modest survival. If you give the nanoparticle alone, because of the target is being there at low basal levels, you get a non-significant, similar to radiation. However, if you give nanoparticle plus drug at these reduced doses, you get a marked, these guys die here. They live up to 60 days. So in a genetically engineered model, treating at very late stages, this is actually a great result. And it's not just blood-brain barrier leakiness, because if you give radiation plus the free drug at that same dose, there's no change, okay? And then the idea is if they're less toxic, and I'm gonna go in the last minute if you don't mind. The problem we do in pediatric brain tumors is we test all these drugs in adult mice, and a lot of these developing pathways are not active in adult mice. 10 years ago, Tom Curran showed that if you gave these same hedgehog pathway inhibitors to juvenile mice, one single dose at P10, They all lost weight compared to controls. They were all smaller. This is x-rays. They all had shortened forelimbs and premature growth plate fusions. It didn't stop the clinicians from doing clinical trials despite this data being out there. And it's actually every single kid ended up being essentially stunted growth, premature growth plate fusion. So we asked, can we get by that? So we took juvenile mice, did the exact same thing. When you give that free drug, smaller mice, they lose weight in the red, but our nanoparticle at the doses that are effective don't. They maintain their weight. Their trabecular bone, this is micro CT, is actually preserved compared to controls, as opposed to the paucity you see in the free drug. That's what's expected. And when you measure femurs, again, the free drug, they're much shortened compared to controls and are nanoparticle treated. And I won't go into the mechanism, but that's what took so long to get this paper out. But we think this is an active transcytosis pathway that through binding of P-select, the nanoparticle, which is essentially like mimicking PSGL binding to P-selectin, you're actually activating a pathway where caveolin-1 is upregulated and to the surface, takes it across the BBB through the endothelial cell. And we took drugs that blocked either Catherine-coded endocytosis or caveole-dependent endocytosis, and it was only the caveole-dependent endocytic inhibitors that reduced the entry into mouse brain endothelial cells in vitro. And genetically, if you remove now CAV1 in the mouse, as opposed to getting nice localization, you only keep it in the vasculature. And this is consistent with our inability to block glee signaling in the downstream target as opposed to the controls. So our model for this is we think that we can use radiation to encapsulate lots of drugs, not just for medulloblastoma, but if we can use it as an adjuvant therapy or even at recurrent stages with low dose radiation, because that is a strategy, we can maybe then employ a strategy to get things across these tight barriers. I'm hoping easier barriers like GBM, leakier barriers would be a lot easier, and that's our next stop. We've made nanoparticles for EZH2 inhibitors, and at least a proof of principle, we can, with the drugs rather than genetically, we can also induce that CDK inhibitor. So we're just finishing those survival studies. Again, I think sporadic modeling is a little closer to human modeling, human models, I hope. EZH2 can promote tumorigenesis through, we think, inhibition of senescence. And we think that's through P16 induction, a well-known senescence marker. We think P-selectin targeted nanoparticles, we can get them to translocate the BBB in tight barriers, and that low-dose radiation can enhance it. We can reduce toxicity, again, because the therapeutic index has been reduced. And this opens up the possibility of using combination therapies now. Because if you can get away with 2 drugs, 3 drugs at 10 or 20%, you might be able to overcome the combined or synergistic toxicity that isn't currently encountered. And then my collaborators, this is my group. Most of this was done at Weill Cornell with collaborators, Dan Heller and his group at Memorial Sloan Kettering. Our human pathological studies, Matija Snuderl is the director of molecular neuropathology at NYU, and our bone toxicity studies and our funding sources. And I'm very excited to be here. We're looking for, my lab gets up, we're looking for very motivated people to help continue. We can go in lots of directions, and would love to talk to anybody who's interested about it.
Thank you so much, Praveen. That was a great talk. We're going to give a few minutes for questions, but I know a lot of people have to run off to the OR, so I want to give Dr. Betterson a chance to make one more announcement if he's still on before we give people a chance to ask some questions.
Well, it looks like we went a little late there, but I know Dr. Betterson wanted to highlight the PA teams at Mount Sinai West and Mount Sinai Hospital, and just say happy PA week, and let everybody know that this is a cause for celebration for the great team that we have here and built, and great job, everybody.
Praveen, this was a fantastic, incredible lecture. Congratulations. You've shown us so many hurdles and how elegantly you have been able to overcome most of them. So congratulations. I have many questions and many comments, and we will continue offline so we can go to the operating room. Thank you so much.
Thanks so much.
Hey, Praveen Kostas here. Great job. Really enjoyed the talk. I think one area that is actively being explored is this whole concept of senescence, I guess, and how you know, cells in and around the tumor can kind of promote recurrence and initiation of stem cell formation, et cetera. Is that something you think with medulloblastomas is also occurring? You told us a little bit about that.
Yeah, I think because it's an embryonal tumor, you're getting very close to a stem-like phenotype. So I think when you're at that stage, I think my thought is as these cells are unregulated, the intrinsic senescence mechanism is still intact. Not every tumor has that, right? So you can imagine maybe they have other additional mutations that prevent senescence, and that's how many tumors lose CDKN2A. For example, they lose that locus. Medullo, at least hedgehog medullo, doesn't seem to. DIPG doesn't seem to, because we know that in at least preclinical models, you can induce it and with EZH2 inhibition. There was a nice Nature Medicine paper a few years ago. Humans, we don't have a lot of DIPG samples. And so I don't know if anyone's looked in the untreated DIPG if P16 per se is active or not. But I think senescence is it's a natural phenomenon. So I think that's what I was didn't articulate well, but the idea is if you can use neurodevelopmental mechanisms of differentiation to your advantage, and because many of those mechanisms, I think in other tissues are not active anymore because they've already differentiated. So tumors, I think we go back to a very early primitive phenotype. And so maybe if you can selectively get your agent to that area, I'd love to kill the cell, but short of killing the cell and removing it, I think if you can stop it from dividing. And the important thing, a Cell Reports paper came out in June. They didn't do this in vivo, at least with a tight barrier, but they showed that once you can use EZH2 inhibition in hedgehog medullo, it's a permanent event. They don't come back. So I think senescence has always had this idea that it's a permanent event. I don't know if that's been proven, but at least in some contexts, it's like medullo, the paper I've referred, it seems to be irreversible.
Great, thank you.
Hey, Dr. Raju, this is Alex Schupper. I'm one of the PGY2s you met yesterday. Thank you so much for the talk. I really enjoyed it. Quick question as we learn more about some of the tumorigenesis markers of SSH medulloblastoma. How do you think this is going to translate not just to the bedside, but to the operating room? Do you think as we learn more about these different pathways, we'll start treating these certain markers as more toward how we treat DIPG in terms of, less of a cytoreductive role? Or do you think that we'll still have more of a homogenized treatment, at least initially, in terms of surgical management?
That's a great question. Actually, Michael Taylor had a very nice paper 8 years ago when he first defined the 4 major subgroups of hedgehog medullo. As a surgeon, you want to try to get gross total resection if it's feasible, right? Because for additional therapies, the less tumor you have, the better. But what he showed was that it wasn't the extent of gross total resection that determined outcomes. It was the molecular subgroup. So if there are areas where you might not be able to get something out, if you know from the molecular analysis, you may not need to worry about getting everything out. And if we have biomarkers to assess for that before surgery, that would be helpful. So what more recent work based on that is that, are there radiographic markers that help you predict one submolecular subgroup versus not? And then a side project I couldn't get into, but we have a project where we're using serum-based and CSF-based markers to predict molecular subtype. And again, that could be useful for surgeons prior to going in because, hey, I don't need to get close to this. Let me just let the rest of the stuff, do the work. So that actually, there's data out there that suggests it's the molecular subgroup for hedgehog medullo that determines outcomes, not extent of gross total resection.
Great, thank you.
But I still encourage you to get as much out as you can.
All right, I think that's it for today. Thank you again, Praveen. That was really a wonderful talk, and we're glad to have you here.
My pleasure. Happy to talk to anyone who wants to know more, okay? Thank you.